Okay, welcome to this first lecture on Introduction to Imaging. In this lecture, we're going to discuss the PT role in diagnostic imaging, discuss some terminology related to imaging, and also discuss fracture management and descriptions. So looking at our role in imaging as physical therapists, in the U.S. military, PTs are considered primary care providers since the early 1970s and therefore are able to refer to radiologists for conventional radiographs, bone scans, and MRIs. So they actually have a very expanded role in the management of musculoskeletal care in the military. Outside of the United States, Australia, about 74% of physiotherapists there refer for radiographs. In the United Kingdom, there are extended scope providers with additional training who are able to refer for radiographs, and New Zealand can do this as well. So the question is, are we qualified to order radiographs? So they took 182 military-trained PTs and compared them to physicians and nurse practitioners in regards to orthopedic knowledge, and the PTs scored higher than all groups except for the orthopedic surgeons. So as PTs, we do have the ability to and experience to be able to order imaging and to look at and manage musculoskeletal problems. We're also equal to orthopedic surgeons with regard to clinical diagnostic accuracy as with these conditions. So looking at direct access and comparing ourselves to others, we are in good shape as far as knowledge and ability to perform our job duties regarding to orthopedic care. So one of the arguments is that if you gave PTs access to imaging, that this would increase cost. The Department of Defense analyzed this and found that the PTs in the military reduced the number of radiological exams by greater than 50% compared to physicians in low back pain patients. So it shows that we are better able to manage low back pain better than with less cost than some of our medical colleagues. There was also in this study a decreased duration of episodes of care, so less visits and less x-ray use and physician referrals on this study. So less than 4% of these PTs actually sent their patients to an orthopedic surgeon. So they utilize their direct access and return these patients back to a satisfactory environment according to the patients and even with the physicians. So state practice acts, so some of these like x-rays and radioactive materials for diagnosis or therapeutic purposes specifically are prohibited in 29 states and are really not mentioned in 20 other states. In Texas, we are prohibited from using x-rays for diagnostic purposes. So we can suggest and recommend for these imaging modalities in the state. In Arizona and Wisconsin, they are able to order x-rays and imaging directly. So hopefully that will come about in a good period of time. So with each imaging study, we know that there are some limitations. There are some advantages to certain imaging modalities, and there's some disadvantages of these modalities that we have. The different studies are more appropriate for diagnosing certain conditions. For instance, stress fractures usually don't show up on a radiograph immediately. So CT scan, bone scan are probably better options for those. We also need to know what information we need for these studies and realize that there is a risk in every imaging modality. There's a certain amount of risk. Radiation is a big one with a lot of radiographs and CT scans. There's a significant amount of radiation that the patient's going to be exposed to, and therefore we need to keep that in consideration. So, analyzing this benefit to risk ratio is important as we order these, if we are able to order these images. So our indications, like I say, should be based on our clinical exam and history that we have taken from the patient, and then deciding if there's an imaging modality that is needed to verify the suspected diagnosis or to exclude a diagnosis in some cases. So we really don't need to just order imaging for everything. Be selective in what you order it for. Is it really going to clarify the diagnosis or exclude a diagnosis that we need to get a handle on in order to best treat this patient? So trauma is one. If we have cord compression after cervical trauma, differentiation between fractures and strains, and even causes of joint pain are some examples that we may need to order imaging or suggest imaging for. So other times it's not always clear with some conditions. So some of our limitations, particularly with conventional radiography, is that stress fractures, non-displaced fractures, early mineral loss in some of these bony lesions doesn't show up well on radiographs, and soft tissue pathology especially is not well demonstrated on radiographs. So therefore we might use CT or MRI to get a better idea of what's going on. Also need to realize that certain things need to be protected. Thyroids, breast tissue, reproductive organs all need to be protected during radiology procedures. Typically they utilize shields, vests, gloves, collars, those various types of things to limit the exposure of these organs. And making sure we get the appropriate imaging view or views needed for these studies. So by decreasing the number of studies that we utilize, particularly maybe we just need an AP and a lateral view and not the oblique, and some of these specialty views with some of these conditions may also help decrease the exposure to the patient. So some considerations. So make sure that we're using the appropriate imaging modality. We want to provide one that provides the least risk to the patient, that's the least amount of cost to the patient. And then if we're unable to order imaging directly, which in Texas we are not able to do that, we can recommend certain studies to the physician for consideration. We also have some clinical decision rules, such as the Ottawa knee and ankle rules and the Canadian C-spine rules, which you know about, that gives us direction on when to appropriately order imaging. So it really comes down to we should probably only order imaging when it's going to alter our treatment plan. So if it's not going to change your treatment plan, you probably don't need an image. So in summary, basically, we want to order appropriate imaging. We want to know which modality or study is appropriate to request based on the patient's condition and suspected diagnosis. We want to be able to read and understand some of the radiology reports, and we'll cover that in the next lecture, and be able to incorporate that information into our treatment plan for this patient. Understand how findings on the imaging may affect your treatment decisions, such as stress fractures and other diagnoses. And we want to be able to discuss intelligently the patient's history, findings, and suspicions with the physician and or radiologist, and integrate them with the discussion of findings even on images with these professionals. So hopefully this kind of gives you an introduction into imaging and what we'll be looking at this semester. So if you have any questions, don't hesitate to email me, and we'll discuss this further as needed.